Good evening. I'm Ken Tabor, Chair of the Phelps Community Board, and I welcome you all on behalf of Phelps Hospital. This is the first installment of our new series to showcase exciting developments underway at Phelps. We are making many significant new investments that will allow our exceptional caregiving team to do more for the patients we serve, all right here at Phelps. Tonight, we're focusing on our new PET CT. You'll hear in a few minutes about what a game changer this will be for our hospital and our community. And this is just one of the exciting projects underway at Phelps. This brief film will give you some of the highlights. Please take a look with me as Phelps leaders look forward.
Phelps has always been a community hospital that really does big things. When I think about what makes me proud to be at Phelps, hands down, it's the staff. It's the whole team. Whether they're providing direct care or indirect patient care, they do it every day with kindness. Their resiliency shows through. They really are a remarkable group of people.
It's almost like family. And I think that we've been able to really build and retain a small community hospital culture. That culture then trickles down to the patient. So I think the patient experiences that also. So I'm very proud of the staff for what they do every day. The experience of the nursing staff during COVID was certainly one that no one had ever had any experience with in the past. At one point in time, every patient in the hospital was COVID positive. Early on in the pandemic, we submitted a document to the American Nurses Credentialing Center. That organization deems hospitals magnet hospitals. And magnet status it's really the epitome of nursing excellence. We were deemed to be a magnet hospital, our initial designation in October of 2020. We had a very generous donor who created an endowed scholarship for nursing, and it really is something that will help us to support our staff and to fill our nursing positions. So I think that was really the highlight of last year.
We work together as an incredible team, and I think that's a good foundation for the hospital to have. I think, again, that's the best way to offer the latest, the best, and the safest care to our patients. It's coordinated care. We work together, the whole team. We're very proud of our residency programs here at the hospital. We've had our family medicine residency program here for more than 10 years. We bring in bright, wonderful, engaged, knowledgeable residents. As of this year, we actually now have added surgical residents, and we right now have 4 surgical residents rotating through our surgical program, and it's been incredibly successful. It makes the facility of the hospital more academic. There's more learning going on. It raises the bar. It's wonderful. It really raises the level of the hospital. When we plan our strategy on how to either grow our services or add new services, we know that part of that strategy is not only bringing in the right person, the right providers, but bringing in the right technology so the physician has the tools and equipment they need to offer, the most advanced technology, the safest and best care to our community, our patients.
We have 4 major projects going on right now at the hospital, large construction projects that represent years and years of planning. Right now we're focusing on 3 major clinical strategies. One is neuroscience, another is cancer, and lastly we have surgical services. Another project that we have is what we're calling right now the Center for Advanced Procedures, which is an interventional radiology suite that will focus on really advanced neurointerventional care. We're building neurosciences at Phelps. We are an advanced stroke center. In fact, we're working towards becoming a Joint Commission thrombectomy capable center, which is only the 2nd in Westchester County. We will be a Joint Commission thrombectomy capable center in the next year, and that will be probably the biggest clinical advancement that Phelps has seen in its history. People used to want to go to the city in order to get advanced care, tertiary care. And now they don't have to do that anymore. They could stay close to home and get advanced care right here in Sleepy Hollow. The complexity of care I expect to just continue to increase. One of our clinical pillars and focus areas is mother-baby and maternal-child health. And we've invested an incredible amount into rebuilding our entire inpatient maternal-child health program. Right now, one of the construction projects we're working on is the mother-baby unit. Phelps will be a premium place to deliver your child. We're very excited because it's so unique, it's so beautiful. There's nowhere else you could have a baby while looking over the beautiful Hudson River. So in some ways, the construction projects represent the end of the planning of our strategy and the beginning of the future.
I think we're very blessed to have a community and donors that are so interested and engaged and generous to the hospital and to the staff. You know, during the last 18 months, during the pandemic and afterwards, it really highlighted that support. It's hard to express the gratitude you have for everybody involved in this endeavor. And on behalf of the hospital, I can't say how grateful I am and how proud I am to work at Phelps.
Good evening. My name is Michael Glennon, and I am the Assistant Vice President of Ancillary Services here at Phelps. Many of you know me from working in radiology for many years, and I am very proud to be part of this institution for over 30 years. As you've just seen in the previous video, there are many things going on here at Phelps. This PET-CT project is the most exciting project I've gotten to work on in my career at Phelps. It is the missing link in the circle of care for oncology patients. Previously, they had to travel to places like Long Island, Nyack, and New York City. Right now, they can get this in their backyard. As I was designing this space, the most important concept for me was the patient experience, their privacy, safety, and quality. This project is a dream for me, so please follow me while I give you a tour of this exciting space. This is the separate outpatient entrance. As you can see, it's conveniently located right off the main corridor of the hospital. This is the private outpatient entranceway. And please keep in mind this space is under full construction, so you're walking around slowly and safely. Patient walks in there, comes right to this station to check in. This is the station where they can stand up or pull up in a wheelchair. The next station is a private registration area. There'll be a sliding door here so they can come in and sit down and need to talk and discuss some private issues. Then we move down here, and this is a private scheduling office. The main complication with this room was to make it merge with the existing CAT scanner room. Now beyond that door there is CAT scan, and there's a private restroom for patients. This is the main patient waiting area. There'll be chairs all along this wall here. Patients will have soft music in here. They'll have a TV also to watch if they want. Once they're ready to get an IV put in, they can conveniently right down here. This is a private IV insertion room where there'll be a nurse in here. There'll be a door here. And after they have their IV in, they walk into the main space. The patient enters into this space here. They have a private dressing room, a private restroom, and it's a subway area. Let's take a quick look in here. As you can see, the restroom is already tiled. We're starting to see some paint trim, so it's really coming together. After the patient is changed here, there's a small subway. They sit here and wait to be called into the scan. Once the patient comes out from the changing room, they come back down this way. This is a special private toilet, which we call a hot toilet because they have radiopharmaceutical in them now. And then the patients are brought to these, what we call a quiet room or a cool down room. There's two rooms here. The patients have their own music control in there, again, for their own privacy and softness, and have a comfortable setting. There's also medical gases in these rooms for safety. Then in the back corridor here is the radiopharmaceutical hot lab, which is where the radiopharmaceuticals are kept away from everybody else in a safe place. After the patients come out of their quiet room and they're ready to be scanned, they come down the hall this way. They come in toward the scan room. Right here is where the technologist stays. This is a control booth. And as you can see, there's a large window in here for safety reasons so they can look into the room to see the patients at all times. The outpatients then come in through this doorway into a large spacious room. On the right-hand side here, we have counters and sink and supplies. We also have some specialty lasers that will come out into the room. These are going to be used for some special oncology, merging of images, things like that for the patient. And then from there, the patient will come in and go on to a table here. This is for patient safety again, if anything is needed. It's great to have all this extra type of safety stuff in the room. And then back here to my right is the equipment room that supports everything that runs in this room. You may be able to see this on the floor. This is the outline for the PET scanner right here. It's quite large. It's angled this way for a reason, so we can see the patient from the control booth through the large window. As you can see, this room is extremely large. It was done on purpose because if we have emergencies, there's plenty of room to bring in support staff to help out. We're also going to do some interventional radiology studies in here on the CAT scanner. This PET CT is also able to do some regular CAT scan patients, so we're very excited about that. As you can see, when you look up at the ceiling here, there's still a lot of mechanical work going on. They're still bringing in electrical, air conditioning, and so on. So I know it looks like it's not finished, but within a week or two, we should start closing this up. The scanner itself is actually being delivered on November 16th, so it's an exciting day for us here. This is a separate inpatient entrance. It's important to separate the inpatients from the outpatients. So when they come through these doors, there's a nurse station right here in case they need to do a safety handoff to make sure they have any questions and answers about the patient. Then the patient is brought straight down this corridor, and then we're going to be turning around here. The patient is then brought down this corridor to a private holding room. Again, this room is equipped with medical gases for safety. There'll be a computer in here, a workstation, a sink, and supplies. It's a nice private room so the patient's away from the rest of the activity in the space. This room next to it is a supply closet that's controlled, climate controlled, so we have temperature and humidity controlled. This protects the integrity of the medical supplies that we have when we're using them on patients. At the end of the corridor, there is a supervisor office and a housekeeping closet here, so these people can keep track of what's going on in this corridor from the supervisor office. Right across from the patient private hold area is a whole counter work here with different things. There's a blanket warmer here for patient comfort. There's an ice machine in case they need some water. There's also a fridge. There's other supplies and some cabinets for storage here. Thank you for joining us this evening. As you can see, a lot of thought went into the design and the safety aspects of this project. That concludes our hard hat tour.
Good evening, everyone. I'm Robin Scotlock. I'm a family medicine physician, and I'm VP and Associate Medical Director at Phelps Hospital, and I'll be the moderator of our panel tonight. I hope you found this virtual hard hat tour interesting. What a huge, big space, and we're going to be talking about the PET CT scanner that's going to be occupying it for the benefit of our community. Part of what we're doing is we're going to be having this panel now, and we have 3 panelists who I'll be introducing in a moment. Tonight, I want you to understand this is a very interactive affair. Because of technology, we have a question and answer box on the screen. So as you're listening in, please type in a question and we'll make sure to get it to the panelists to answer. So let's go ahead and jump into our session. I want to introduce first our panelists. Our first panelist is Dr. Toby Bank. She is a physician boarded in internal medicine and geriatrics. She serves as our SVP and medical director at Phelps Hospital. She's an assistant professor at New York Medical College. Thanks for joining us, Dr. Bank.
Hi, good evening.
Our next panelist is Dr. Tony Feblis. He is boarded in internal medicine. He did an internal medicine residency. He's boarded in radiology. He had a fellowship in interventional radiology. He serves as the director of radiology at Phelps as well. And he is an assistant professor at the Zucker School of Medicine. Thanks for being with us, Dr. Feblis.
Good evening, everybody.
And our third panelist is Dr. Anna Komorowski. She did an internal medicine residency program as well, and she's boarded in medical oncology and hematology. and she is the medical director at the Cancer Institute at Phelps and is an assistant professor at the Zucker School of Medicine. Dr. Komorowski, thanks for joining us.
Good evening, everyone.
So to get started, we've been talking about this PET CT scanner. You know, that's a lot of letters, it's big acronyms. So Dr. Feblis, could you help us demystify this? What does PET stand for? What does CT stand for? And how does this work?
So PET stands for positron emission tomography. It's usually combined with CT, which is computed tomography, CAT scans. And basically, a PET scan is really used to evaluate and diagnose and detect usually cancers by injecting FDG, which is fluorodeoxyglucose. And it's basically injected into the patient, and then using gamma rays and detectors in the PET scan, we can find out where tumors are and the degree, of which the tumors have progressed or not progressed. And so it's a very, very powerful diagnostic tool. And it's usually used with CAT scan as well.
Oh, great. And tell us about a CAT scan. What does that do?
So basically, CAT scan, which I'm sure everyone's familiar with, many people have had it, is radiation. It's basically computed tomography and gives us a very accurate, detailed picture of the inside of the body. And also, it's for diagnosis. And the reason why we use it with PET is that it helps us get better pictures for the PET scan, and it also gives us very exquisite anatomic detail in addition to the physiologic detail that PET allows. And the two combined together gives us incredible amount of information about the disease process.
Thank you. And this machine sounds so big and powerful. I think we have an image of what it's going to look like at Phelps. Can we project that image here on the screen so we can look what a patient would expect to see when they come to this this PET CT scanner? So here's the waiting area. You can see how beautiful it's going to look in the next few weeks. And then let's go on and see what the actual room looks like and what the machine looks like. So there it is. So you know what I find interesting about it, Dr. Feblis? We're talking about a PET scanner and a CT scanner. I see one sleek machine. Is it all just in one?
It's all incorporated in one machine. The CT gantry and the PET gantry have different detectors, but they're side by side next to each other, and they're basically imperceptible. They're in the same, what we call a gantry, and it's just like a donut where the patient's kind of going in and out. So they're both together, and it makes also the tests go by much faster, keeping everything together.
Does a patient always need both a PET scan and a CT scan when they come in?
They do. Part of the reasons why we get the CT, in addition to the anatomic detail that CAT scan gives us, in addition to the PET scan information from the physiologic uptake of tumors by glucose, is that the CT also gives us a map of how the radiation goes through someone's body, and it helps when we inject the FDG, the radioisotope, into a patient. It gets attenuated, meaning that the gamma rays go through the body, but they get stopped and slowed down. And CAT scan gives us a way to map out how slow and where exactly and why each photon gets delayed. So it gives us it helps us gives us an attenuation map in addition to anatomic detail.
Great, thanks, Dr. Feblis. I understand it's been a long time coming. This is a very expensive machine and it takes a lot of planning. Dr. Komorowski, as the director of our Cancer Institute, I understand that this has been a dream of yours for a long time. Can you talk about that?
Oh, yes, and definitely. So I want to say that we opened the door of Cancer Institute at Phelps almost 5 years ago. This coming January is going to be the 5th anniversary when we start seeing our patients in the community. And as our services expanded since then, we implemented clinical trials, we do complex chemotherapy treatments, we collaborate with other centers and our colleague specialists. We also knew that this is crucial for us to have a PET scan. PET scan is essential in oncology. We have multiple applications. We detect cancer, sometimes helps us to identify where is the cancer. Determines where the cancer is in the body, also helps us to identify which area is the best to biopsy. When we see hungry cells, the cancer cells that basically inhale, that die, and we see the hot spots, it makes us understand that this is the area we should, for instance, biopsy. It helps us to assess the effectiveness of the treatment. So if I see the activity in the body from the particular condition and I start the treatment, then I know if the patient's responding to the treatment by repeating the scan. It also helps us to understand if cancer has returned after treatment. So if we treated the patient is a complete remission, doing very well, and there are some symptoms or particular findings in the blood that would concern us about the recurrence of the cancer, we will reevaluate the patient with the PET scan. It helps us to understand a little bit better the prognosis of the patient. It helps us understand which area is viable after the treatment, and determine how to better treat the patient or identify the proper treatments.
Thanks, Dr. Komorowski. Dr. Bank, I understand that it's taken a lot of work for the hospital to get this here. We didn't just have a open space waiting for this machine. What had to happen here to allow space for this machine to be brought here?
Thanks, Robbins. Yeah, it's been a lot of, as Anna pointed out, there's been a lot of planning. This is in line with one of our major strategic endeavors right now, are the building and growth of our cancer center, our comprehensive cancer center. So there's been a lot of planning. We're incredibly excited about having this addition for our comprehensive cancer center. As Anna pointed out, it's going to allow us to better diagnose and treat and monitor our patients. And as you could see with Michael's tour, this takes up quite a large area of our fairly limited space in our hospital. We're not a huge institution, but you could see, the space that's been dedicated to this because it's such an important thing here for us. This is in the main corridor of our hospital. We had to move many things in the main corridor. We moved the gift shop among other things to clear the space for this. And it's wonderful, I think, that it's going to be, contiguous with our location of our radiology services now and in our main corridor. It will be very, very accessible.
How impressive. It's a lot of work. So going back to technology a bit, Dr. Phelps, I understand that there's different types of PET scan studies that can be done. Can you elaborate on that?
So generally speaking, the most popular or the isotope that's used the most is FDG. That's fluorodeoxyglucose. And basically it acts as just a regular glucose molecule. And what we're looking for is tissues or particularly tumors, for example, that are taking up the glucose at a very high rate because the tumors have expressed glucose receptors and also enzymes that keep the glucose within the cells. So FDG is the isotope by far that we use for oncologic diagnosis and evaluating for recurrence. But there's other very important isotopes too that we use. One of them is, for instance, dotatate studies that are more sensitive for what's called neuroendocrine tumors, and they are specifically have a antigen that will attach to, for instance, neuroendocrine tumors, and give out the same kind of information that FDG will. In addition, there's some really exciting isotopes that are on the horizon that are very specific for different tumors. For instance, one of the isotopes called Seriana is very important and very exciting for us in terms of diagnosing recurrent breast cancer. That's what's called estrogen positive. So based on histology from biopsies, if a tumor is estrogen positive, then we can use this isotope to identify the extent or recurrence of of particular types of breast cancers. And we can do a similar strategy when we're using other markers for prostate cancer, for instance. And the isotopes and the antigens that are linked to those isotopes are becoming very, very specific and incredibly helpful in their sensitivity and specificity for detecting disease, but also detecting recurrence or evaluating patients after treatment.
Thanks, Dr. Fedlis. To this point, we've been talking really high level about what this machine can do. I want to hear stories about how you helped patients using a PET-CT scanner. So could each of you take a turn and talk us through a patient that you were able to make an impact with by using this technology? Which one of you would like to go first?
So I think that what we can do like we discuss the patient the same way we discuss the patients in our basically almost every other day conferences, that when we meet together as a multidisciplinary team and we have medical oncologists, radiation oncologists, interventional radiology, we have also surgeons, and this is when we define, work and collaborate together to detect what's the best pathway for the patients regarding the treatment or further workup. So I'm going to present a case. We're going to talk about lovely Mr. B. He's 81-year-old. He's a former smoker. He had already diagnosis of the bladder cancer, and he's very functional. He loves his wife, and he's very important caregiver to his wife who is disabled. And he was undergoing evaluation with one of his physicians when the CAT scan revealed that he had two masses in his lungs. One was on the left side, one was on the right side. At this point, the patient was referred to us, and this is what we proceeded with, the PET scan. Tony, do you want to show the PET scan?
Yeah, can we see the images? Can we bring up? So one of the original indications for PET scan in the history of PET scan, when it was being evaluated by the CMS for payment, is the indication for lung nodules, and PET scans are very, very important in evaluating lung nodules to determine whether or not these nodules could be malignant or benign. So, in general, more malignant or cancerous nodules tend to take up more glucose, and this is a coronal image. So the patient is, it's obviously that the patient is facing us, and this is a single slice from a coronal image on your left side that shows two foci of FDG avidity. What that means is that the FDG, which acts like glucose, is being taken up, and this is called FDG avid nodule. So this is, or otherwise colloquially known as it's a hot nodule. And we also see an area of FDG avidity within what's called the mediastinum. So this is very concerning for us that this nodule is cancer, number one.
Dr. Fedlis, I see two bright spots right up there in the top chest. Is that right? Those two bright, shiny spots?
That's right.
You're saying both of those are potentially cancer?
That's right. That's right. So these two spots are consistent with taking up a lot of glucose and being very metabolically active. And basically that increased metabolic activity is very suspicious for cancer, especially in the setting of a patient who Dr. Komorowski had mentioned has a history of smoking. On the other side, so if we're going to the right side, we see that there's another small focal nodule that also has a lot of uptake of glucose as well. So that's very concerning that we have two nodules that are relatively small, but in one in the right lung and one in the left lung. So in a patient that is has a heavy history of smoking, we're concerned whether or not these are two separate cancers or they're the same process, the same kind of cancer. And this is one of the things that PET helps us determine, because a lot of smokers just have small nodules that are not PET positive at all, and probably aren't cancer. This is where PET comes in, and it becomes very, very helpful.
So when we identify the patient has two spots in the lungs and one has on one side, we see also involvement in the lymph nodes. I referred the patient for workup, and we proceeded with biopsy. Initially, we biopsied the lung nodule on one side. When we knew the patient is doing well, we proceeded with the biopsy on the contralateral side. And the biopsy revealed that we were dealing with two different types of lung cancer. One was a subtype that was faster growing and was concerning for us. It was a neuroendocrine, poorly differentiated cancer. And the other one was adenocarcinoma that was expressing a PD-L1 markers, which was indicative of the patient being a good candidate for immunotherapy. Given the fact patient's age, also his underlying comorbid conditions, as well as his important, preserving his function well, I knew that he's not a good candidate for aggressive chemotherapy. He was also not a candidate for surgery. So again, we met together and discussed options for the patient's treatment. On my side as a medical oncologist, I thought the patient is a perfect candidate to start immunotherapy. But my concern was that the other lung nodule that was fast growing, maybe not, and it's smaller, maybe not responding to immunotherapy. So again, I called Dr. Febles, who I talk to a few times a day, and I asked him, what can you help? Well, how can you help me?
So we went forward, and so he was on serial PET scans that were performed after chemotherapy. We saw that the one on the right was responding, the one on the left not so much. So we decided, because he wasn't a very good surgical candidate, we decided to proceed with what's called a thermal ablation. So what I do is under CAT scan guidance, and now you guys are experts in CAT scan, we basically introduce a needle, and I go right through the nodule under direct visualization using CAT scan. And at the tip of the needle, there is basically a device inside the needle that freezes the tumor to temperatures that are extremely cold, -40 degrees Celsius, and basically causes frostbite and kills the tumor. In addition to the tumor, it's important to get a negative margin. So we want to get not just the tumor, but around the tumor to make sure that there's no recurrence. And we can do this again, everything with minimally invasive interventional radiology procedures. And we did that in this case, and it was very successful, given the size of the tumor and we got an adequate margin. So we repeated the PET scan. If we can go to the next slide. Can we go to, there should be one more image after treatment. So basically, this is the follow-up after the patient received chemotherapy. We don't have any tumor or any evidence of FDG avidity. There's no hot spots on the right side, and the left side, there's a little bit of uptake, and we can put a measurement on this and get a number of what's called the SUV number. And this is a number that correlates with the degree of how hot something is, how much FDG it's taken up. So this small amount of uptake is very similar to active muscles. And this is an area of inflammation, which we expect to see after the cryoablation. So this is considered successful. And CT scans have also shown that the size of the nodule on the left has also decreased in size, and he's done very well.
Yeah, so this was, I want to mention that this was actually 2.5 years ago. And Mr. B still takes care of his wife. He even put the tattoo on his arm saying, "I love you," when the wife couldn't really, was doubting if he loves her. So it's a very touching story for me. But what I want to bring it from the patient perspective is that we did all of this with the great support from the patient family, but also we had to send the patient outside our institution. And every time the patient had to do the trek outside the institution, have a PET scan, then we're waiting for the report, and also have to obtain the CD. So, because it's crucial for us to, with Dr. Phelps, to review those images together and identify what would be the best treatment, then the CD has to be uploaded to our system, and then we do it, and it takes time. And just kind of, I'm so excited we're going to skip this process, that we're going to have it in our backyard available immediately. It's really a very exciting time for us.
What a great case. Thanks for sharing that. What an impact you had on the life of Mr. B thanks to this technology. And it'll be so nice to bring that here to Phelps, where he could do it in his own backyard. Dr. Bank, can you share with us a story about a patient of yours who's been helped by using a PET CT scanner?
I think what I'd like to get across, maybe not a specific case, but just I'll put on my geriatrician hat for a moment. I think most people who've heard of PET scans, PET CTs, equate it with diagnosis and treatment of oncologic conditions, of cancer treatments. I think what many people aren't aware of is that another very impactful use for PET scans is in the diagnosis and the treatment of dementia, of cognitive disorders. And having a PET CT here is going to be instrumental in our geriatric practice. There's a big strategy movement in Northwell, in Phelps. We've had this here for years. We have a very active geriatric practice here. And one of the main reasons patients come to see us is for cognitive disorders. They feel like their memory just, isn't what it was. It's very difficult, as most people know, it's very, very difficult to diagnose causes of dementia. We don't like to do, brain biopsies, which would be one of the ways we could diagnose. So this gives us a modality, a very effective modality, not only in diagnosing, but treatment, in counseling our patients, our families, in what the cause of their dementia might be. There's been some very large studies, I think because Alzheimer's disease is one of the main causes of dementia. Very often we go down that road. We have to put all our information together, but unfortunately we don't always have an exact diagnosis, because it's more of a clinical diagnosis, putting things together, symptoms and neurocognitive testing, but it doesn't enable us to really have a pinpointed diagnosis. And very often we start patients on treatment for Alzheimer's disease, or vice versa. We think a patient doesn't have Alzheimer's disease and we don't start them on treatments that we know can help. With the use of the PET CT, we can actually really pinpoint these diagnoses and distinguish our patients who do have Alzheimer's and those who don't, and then continue to look for the causes of dementia. And our patients who know don't have Alzheimer's disease, not be sent down the wrong path, but down the right path. And these causes of dementia are actually all treated very, very differently. Whether it's a vascular dementia from infarcts, from strokes, things like Parkinson's disease, Alzheimer's disease, we treat them very, very differently. And actually the treatments for ones can actually make the other causes worse if that's in fact what it is. So this is going to be very, very instrumental. We geriatricians are very, very excited about the PET CT, and we're going to put it to very, very good use. We're going to keep Dr. Phelps and his team very busy.
Dr. Bank, that's so interesting. A lot of people might think of PET CT as just for oncologic cases. Clearly, there's this big use for it with dementias. Dr. Phelps, I understand there may be some other non-oncologic related conditions that this can help evaluate. Can you talk about some of that?
Sure. Brain, as Dr. Bank was saying, dementia is a very big part of the other uses of PET. differentiating Alzheimer's from PICS or Parkinson's or vascular disease, very important, but also, staying in the brain for diagnosing seizure foci. That's also one of the big indications as well. In addition to cardiac studies. So there's different isotopes we had talked about. Rubidium is one of them, and but you can also use FDG to evaluate the heart and basically look for heart muscle that may look like it is dead on a stress test, and it looks like it can't be reversed. If we get a PET scan, we can determine which heart muscle can actually be saved by doing a cardiac coronary artery angioplasties, and that's called a hibernating myocardium. And that's a very important component for a specific subset of patients that have heart failure or a significant amount of heart disease.
Well, thanks, Dr. Feblis. So we're seeing there's multiple different indications for using this scan, not just all cancer related. I do want to go back to cancer again, like how we helped Mr. B. Dr. Komorowski, what are some of the most common conditions in oncology that the PET-CT scan can be used for?
PET scan has multiple, as I mentioned before, PET scan has multiple applications in oncology for different phases, but not all of the cancers are PET avid. So not all of the cancer will be fast metabolic rate to ingest the glucose and be tagged with the radio tracer. The most commonly we use it in the lung cancer. We also use it in the breast cancer, and I'm very excited about Seriana scan, which is used for a particular subtype of a breast cancer called lobular breast cancer. It also will allow us for our patient to understand if they have sensitivity to endocrine treatment, if they have metastatic disease, means if they have estrogen receptor positive on the tissue, because sometimes we see recurrence of the disease and we cannot get to it with the biopsy, or there are a couple of areas, some of them respond to the treatment, some areas may not respond to the treatment. This will be indication to Seriana PET scan. We use also in melanoma. Melanoma is PET avid and is very active, and it's very good to guide us about the extent of the disease. We sometimes use it in certain circumstances in pancreatic and colon cancer, although it's not a routine indication because the CAT scan will deliver enough information to understand the extent of disease. Also lymphoma or multiple myeloma. And lymphoma has a specific indication because when we start the treatment, after 2-3 treatments, we want to understand if the patient really responds to chemotherapy. And at that time, we will repeat the so-called treatment response PET scan, and we'll repeat the scan to understand, is this the patient who is responding well to the treatment for the lymphoma, or is this the patient that we need to consider transplant or another lines of treatment in the future? We also talked about the application in metastatic prostate cancer. Again, the cells may be not fast enough to respond to FDG uptake, but we have a special type of a PET scan called Axumin, which is tags the prostate cancer cells, and we can understand better the extent of the disease. Another one is neuroendocrine tumors with the PET doatate, which will allow us to understand if the patient not only identify where the disease is, but also identify what kind of treatment patient we can use, including somatostatin analogs that may allow us to control the disease.
Thank you, Dr. Komorowski. Well, I'm happy to say we're getting a bunch of questions lighting up our question and answer board. I want to turn to some of those questions for a moment. One question that came in is, do you anticipate using PET scans to monitor the effectiveness of a particular chemotherapy treatment? For example, using a PET scan after a short time period to see if the treatment's actually shrinking a tumor. If not, you might want to use a different chemotherapy medicine, substitute something else in if the original isn't working. Can you speak to that a bit?
Yeah, that's an excellent question. And actually, this is what helps us in understanding when we treat lymphoma. But we also utilize it in different conditions, as most of the treatments require about 2 to 3 months to see the response. Unless the patient has some particular symptoms, we can repeat the PET scan on the average, in about 2, more frequently 3 months. But if the patient is tolerating the treatment well, and we don't have any evidence of progression of the disease, but clinically actual response of disease, we may delay the PET scan even between 6 months to 12 months. We also use in between PET scan, we can use the CAT scan to understand better how extensive is the disease or what is the response. So it's each particular disease and condition requires individual approach and in identification. If we have a condition when there is no activity in the elsewhere in the disease of the disease on the PET scan, we may proceed and do just follow up with the CAT scan. If there is an activity, is that there is an uptake. If there are hot spots that we identify on the PET scan, we definitely want to see how is the response later on.
Thanks for answering that question. Another question that was asked is, when we're talking about medicine, we always have to talk about insurance. This question is about reimbursement. The question is, what's a reimbursement like from insurance for PET CT scans, Medicare, PPO? How does this impact the use of the machine? And maybe not just reimbursement, but we could talk to just how to get it approved. Do they approve these scans in the first place? You've been already requesting these scans for years. Can you tell us what that whole approval process and payment process is like?
Of course, and again, excellent question. PET scan it's an expensive test, and we always want to make sure that our patients are covered properly. So we start with evaluating the insurance and making sure that the insurance covers it. It's also FDA approved test. So it's indicated.
Right.
We have usually no issue with obtaining authorization and evaluating following the indication for the particular condition. Sometimes it requires us to get on the phone and discuss it with the insurance and justify why we want to do the scan. How does it change our management? How it's going to change our action or next step in the patient's treatment. So we are very careful. We're not going to send the patient without checking the insurance for a PET scan, and then the patient will get a bill. We don't want this to ever happen. The disease brings enough stress to the patient that we don't want to add to it by financial burden.
And
I would assume, oh, please go on, Dr. Banks.
I just wanted to say that, CMS had declared because PET CT is such a useful modality in the diagnosis of dementia, CMS actually declared several years ago that Medicare would cover these studies. As Anna pointed out, there usually does have to be some justification, and we have to explain why it is that we need to order this test, but it actually is covered by Medicare as well for diagnosis of dementia.
Which leads me also to the point that this is not an urgent emergency test. This is not a test that we're going to send the patient from emergency room or inpatient hospitalization. This is the test that not only we have to prepare the patient through the insurance, we have to prepare the patient with the diet. The patient has to have low carbohydrate diet the day before. And also we have to make sure that we have proper radioisotope. Those radioisotopes are not stored all the time in our facility. They are all by the order in order for each patient individually.
Thanks for going into that. It segues really well into what we want to talk about next. We've talked about this PET CT scan. We've seen images of it, talked about how it's used. I want to know the nuts and bolts. So I'm a patient who needs a PET CT scan for some reason. I understand there's some prep I have to do. I'm going to be injected with some radioactive isotopes, and I have to prepare my body for that. Dr. Phelps, can you talk about what needs to be done by the patient in the days preceding the test?
Sure. So what we ask of the patient is to, around 24 hours before the test is performed, we ask them to have a low carbohydrate diet. And that's basically to minimize the glucose And we also ask them to not do any strenuous activity for around 48 hours before, because if you do a lot of strenuous activity, you're activating your muscles, and the muscles will crave glucose. So you don't want to have a scenario where your muscles are taking up the FDG as opposed to the tumor, for instance. So those two things, low carbohydrate diet, no strenuous exercise before. And then we also want the patient not to eat for around six to 8 hours before the PET scan is performed. This could be difficult with patients who have diabetes, especially patients who are insulin dependent, either type 1 diabetics and some type 2 diabetics that are insulin dependent. It's very important the day of the test that we have a glucose level that's at the right level. For instance, if the glucose level is above 200, which is quite high, a normal glucose is around 120. If the glucose level is too high, that amount of glucose that someone has in their bloodstream could compete with the FDG, and we may get false negative results because normal glucose will be taken up by the tumor as opposed to our FDG. So that's one of the things that we look for. After we inject the isotope, usually intravenously, it can be taken orally actually as well. But after we inject the patient, we have them sit down in a very quiet room for around 45 minutes to an hour. And that is so that the glucose gets into your bloodstream and gets taken up by the cancer cells so that we can adequately diagnose what's going on. We also warm the patient and keep them very comfortable because there's a particular kind of fat called brown fat that can actually take up glucose in the FDG, and that could also give us a false positive result. So there's a bunch of little technical things that we have to be concerned about in order to get a very accurate test. And finally, after that hour that the patient's been sitting around in a quiet room, we then bring them to the PET scanner and we put them on the table. And you saw a picture of the PET CT scan. We get a CAT scan. The CAT scan takes maybe a minute, and then we do the PET scan. And the PET scan takes around 20 to 25 minutes. And basically the patient has to be still. And after they get that scan, they can go home. That's with some instructions. Basically, there'll be a little bit of radioactivity. We ask them for not to spend too much time with small children for around 24 hours. And also, not a prolonged time period with, a partner for around 24 hours. And in particular for women that are breastfeeding, the FDG actually doesn't go into the breast milk, but when women are breastfeeding, they do have a certain amount of activity in their body. So, we prefer women to not breastfeed for around 8 hours afterwards. They don't necessarily have to, what we call, pump and get rid of the breast tissue. You can actually pump and save that breast tissue because the glucose doesn't, the breast milk rather, because the glucose doesn't get in the breast milk, but they just can't, it's not recommended to, feed during that time.
Wow, what a process. So you're preparing in advance, come into the hospital, and it sounds like it takes multiple hours to really be prepared and go through the whole process. Then, Dr. Komorowski, I'm hearing I'm injected with a radioactive isotope. A CAT scan machine, a CT scan is using radiation. How safe is this for me to get radioactivity and radiation in a scan?
So it's safe. It serves the purpose, and it's safe. Usually, patients tolerate it very well, and the allergic reactions are extremely rare in our patients. Nevertheless, as Dr. Febles mentions, patients remain radioactive for at least several hours. And I have my personal story in this. Several years ago, we had a scare. My husband found a mass that was investigated, and one of the steps was to obtain the PET scan. Unfortunately, we didn't have a PET scan at this time at Phelps, so he had to go to the city. And the PET scan, after the PET scan, he went to work, and then he showed up at the Grand Central taking a train back home. And at the time he was surrounded by several well-dressed gentlemen who stood next to him, and he suddenly realized that there is some attention around him. And then I approached him and said, "Sir, did you have any tests today?" So basically it means that his radioactivity was picked up by the Geiger, measurement, sensor in Grand Central. So he said, yes, he pulled out the card and he presented that he had a test. And he was, "Okay, sir, thank you, you can go."
That's amazing that it can set off machines. Wow, wow, what a process.
But it goes out very quickly. And the most important thing is that the patients are, from my perspective, also well hydrated, because sometimes apart from using the FDG, tracer, we may sometimes use also IV contrast. And so it's very important for us, the patients stay very well hydrated after the process, after the test.
Thank you. This is a long process. It takes multiple hours. One question from a participant here is saying, how many can we do in a day if it takes so long? How many of these scans do you think we'll be able to do at Phelps?
So I think even though it sounds like the process is long, there's different rooms that these processes take to, that can occur. For instance, the injection versus the quiet room versus the actual, PET scan. It probably at this point, maybe around 10, we can, maximize 10 patients a day, which is a very, very good number for, a hospital the size of Phelps.
Great. And then, it strikes me that patients are spending a long time in that day going through all this testing. And in the old days, they used to have to travel outside of their community, outside of their comfort area. Toby, can you talk about how this is going to meaningfully impact our patients?
Yeah, thanks, Robin. So I think this is one of the reasons we're so excited about this modality. Is it's so in line with our strategy here. Our strategy is to build comprehensive services, a comprehensive cancer center where all your doctors are here on site, all your diagnostic modalities, all your treat modalities are here. Your doctors, as you can see, speak to each other every day. You don't have to go drive 30-40 miles down into the city to get a special test. You can get everything you need here, from diagnosis through treatment. You can stay here in your neighborhood where you can see your doctors and get everything you need, all under one roof. And that's the big, I think that's the most important thing that sets us apart, that sets our comprehensive cancer center apart, that sets our hospital apart. It's coordinated comprehensive care right here where you live. It's the highest technology. There's no more, Dr. Phelps, correct me if I'm wrong, but there's really no more advanced technology than this. This is tertiary level care, diagnostic modalities, treatment modalities here in Westchester where people live. And I think, and this is where your primary care physician, your cardiologist, your gastroenterologist, your oncologist, your radiologist, everybody's here working together, speaking together to get you the absolute best care you can have.
Wow, what a blessing to have this technology here for our patients in our community. It's a really great addition to our hospital. I see that we're out of time now. I want to thank our three panelists for their time this evening to explain this technology to us. Thank you for participation, and I'm going to turn the time over to Jill Sibilia.
Thank you so much, Dr. Gottlieb. Wow, what an exciting presentation. Thank you so much for being with us tonight. I hope you enjoyed this first edition of our Insider series as much as I did. My name is Jill Sibilia, and I'm the Vice President of Development here at Phelps Hospital. And the PET-CT project is funded in partnership with capital investment from Northwell, but it's also funded thanks to the generous philanthropic support of many people in the community. And your generous philanthropic support is really helping us to introduce this game-changing technology, as you heard from our distinguished physicians. And I want to thank the growing list of supporters who are supporting this very, very important project. If you'd like more information about ways that you can get involved, you can visit our website at phelpsgiving.org, and that website will be in our chat. And now it is my pleasure to introduce our Executive Director, Eileen Egan, who will close tonight's program. Thank you again for joining us. Eileen? Thank you, Jill. Oh my gosh, this is so exciting. What an exciting time for Phelps. I too want to thank tonight's presenters. I want to thank Michael Glennon for his hard hat tour. I want to thank our panel of expert physicians, Dr. Bank, Komorowski, Dr. Feblis, Dr. Gottlock. I want to thank you, Ken Tabor, and our entire community board for your leadership. And I really want to thank all of you who have generously supported support our PET CT scan project, as well as all the other projects that we have going on here at the hospital. You've heard from Dr. Bank, you've heard from Jill, you've heard from Dr. Feblis that our goal is to provide tertiary care level, high advanced, the most state-of-the-art technology care here, so that you don't have to travel outside of Westchester. And that's what all of this is. And we couldn't do that without your support. You allow us to do that. And how could we ever say thank you? It seems so inadequate, but really our gratitude for all of us here, our practitioners can practice at the top of their games. They're fabulous. So thank you all for joining us. I look forward to our next virtual event, and have a good evening. Thank you.
Thank you, everybody.